Coexisting spinal stenosis and knee osteoarthrosis, what to do? Well, about 25 years back, when I started seeing both low back and knee issues coexisting, and at that time, I had just moved from being a pure orthopedic surgeon, doing trauma, doing pelviacetabular, and doing joint replacements, to a spine surgeon. I was a little bit confused. Why is it that if a car stops running, especially a rally car, what should we look for? Should we look for a problem in the engine, or should we change the tires? I thought I was a little bit biased because I felt I'm a spine surgeon and every time it's the engine that needs to be looked at. And over 25, 30 years, I've realized that the answer is somewhere in between. It's neither my answer, not your answer, but somewhere in between. Hence today, when we see a large number of people, and I'm now touching 60, so in a couple of years, I'll reach a stage where I'll have to decide between TKR or lumbar decompression for myself. And what is it that will decide the way forward? Well, I am very convinced about two things. One, that after LASIK surgery for the eye, which is the most patient gratifying procedure, probably the second most patient gratifying procedure in the world today, elective, is total knee replacement. Why is that so? Because it makes unhappy people very happy for a long period of time. Let's say at 60, I get my knees replaced. I have good quality of life till I'm 80. So this is something which is really a paradigm shift in quality of life. And there's a quantum leap in the way we live. Unfortunately, low back surgery, lumbar decompression, makes unhappy people less unhappy for some time. So as it is, the spine surgeons are actually fighting a losing battle, and it's my duty to try and fight back as the underdog. I have always believed that when patients come to us, they could be in acute, exacerbated pain, unable to bear any pain, and the x-rays may look like the ones to the left. While you may have patients who are walking around, hobbling around with x-rays to the right, and they seem to be living with it. Somewhere in between, we have to find an answer. And I think the answer is that we need to treat the man and not the scan. Is it so only with the knee? No. The MRI to the left looks hardly surgical, while the MRI to the right says, operate on me tonight. Yet, the clinical symptomatology may differ. The demands and health-related quality of life issues in patients may differ. The decision is more important than the incision, and hence it's very important to start with why. Why are we offering surgery for low back, or why are we offering surgery for the knee? The purpose is more important than the process or the product. It's much later that you decide whether I'm doing a lumbar decompression, open, minimally invasive, with implants, without implants. Same way, whether I'm replacing the knee, whether I'm doing cruciate sacrificing, or I'm keeping the cruciate there, whether I'm doing a uni, whether I'm doing whatever, all poly, that's left to you guys. That decision comes much later. The decision is that surgery really indicated? Hence, the three important steps in taking such a decision are counseling, counseling, and counseling, so that we get a right fit as far as which patient needs what. This is probably the most important part of our discussion today. All of us, as we grow old and if we live long enough, will need some overhauling of the lower back and the knees. But when to do what has to be a shared decision between the surgeon and his team on one side and the patient and the caregivers on the other. In our country, we don't deal directly with the patient because the patient is patient plus family, and we as surgeons are surgeons plus team. There are a lot of articles available, and a few of them I shall quote. One, what should we operate? The knee or the spine first? Interestingly, if you compare the number of knee replacements and the spinal decompression fusions done, 2.5 times number of knee replacements happen as compared to low back surgeries. But then we have twice the number of knees. We have 2 knees and we have 1 low back. So it's not unusual that the knees are outnumbering the lower backs. A study was done by the same group, which gave the option, studied and took feedbacks from patients to find out whether they would choose for a spine surgery or a total knee replacement. And what they came out with was that shared decision making is extremely important. When the knee and the lumbar spine are equally symptomatic, we have to go beyond and push the envelope to find out which of the two is really affecting quality of life and to what extent. Finally, such patients who have purely degenerative, they don't have something like a spondyloarthropathy or an inflammatory disease. That means they don't have ankylosing spondylitis, they don't have rheumatoid arthritis, they have standard OA. In this, if the spine is more affected, you go with the spine first. But if the knee is affected by an inflammatory disease, is a valgus, or has major gait issues, then you address correcting that deformity first before addressing the spine. Having said that, there are various papers that have come out, and there's one from our own country, which has even tried to give you an algorithm. The algorithm tells us that you have to actually go with the patient in mind first. Why is that so? Because in our country, there are very limited studies where you're actually looking at pelvic indices, spinopelvic balance, and such things, because these are not really adhered to by the masses. Hence, concurrent problems are addressed mainly with the patient in mind first, provided that both are purely degenerative, the lumbar spine as well as the knee. However, if it is an inflammatory disease with greater deformities, the one with the deformity is addressed first, and this case usually is the knee. There are certain confounders like the hip also being involved. And it is a point which we have to look at, that we have to look at the patient as a holistic human being. So if you have situations where the spine, the hips, and the knees are all involved, you may have to actually weigh one against the other and take a decision whether the rear tires or the front tires need to be changed first, or whether the engine needs to be serviced first. Symptomatology will always be important in the knee, hip, spine syndrome. Hence, you have to listen to the patient silently. Decisions are not made on scans, radiological imaging. We have to look at the symptoms and how their quality of life is being affected. All our answers have to be less objective, more subjective, very personal and individualized. Everybody does not fit into a fixed size. Everybody has different needs. If there's somebody who's mainly homebound and does not need to walk more than 15 to 20 minutes, but has deformed knees, get the deformed knees sorted out first. But if somebody by choice has to walk, they are uncontrolled diabetics, then get their spine sorted out first so that you can improve their capacity and their stamina to walk. So these are individual decisions. The other thing, which I always believe, spend a lot of time in your clinic counseling them. You should not admit them and then counsel them. No, it has to end before the admission. You cannot have counseling starting on admission, whether it's for a knee replacement or whether it's for spine. It's all to be done pre-operatively, counseled, even consented, and then brought in. Despite all this, you will have three types of patients, whether it's for the knee or for the spine. There are some who are very acquisitive. They will always be unhappy. Then there are those who are contributive, who are happy, but they still want more. And finally, you will have a large number who are happy whatever you do for them. And with the knee, be extremely careful. Majority of them do very, very well. Still stick to the rule and execute and perform the surgery with precision. Always find your checklist and always have a purpose, proper planning, proper process, and precision, whether it's the spine or the hip. Always answer these questions. Is surgery the only option? Can I make him or her less unhappy? Is the risk benefit ratio in favor of the patient? If it's the spine, do they need decompression? Do they need fusion? Do they need deformity correction, or do they need a replacement? Or is this patient an outlier? A lot of our patients in the low back are outliers. They have functional overlay. And we've seen so many of these mental issues cropping up post-COVID. Always remember, the happiest patient is the one who buys the surgery rather than the one to whom you're selling a spine or a knee surgery. Always work with a team and work with a partner who will give you suggestions and stop you when you're going wrong, whether it's in counseling or whether it's in execution of the surgery. Have a low power distance index. Someone who may be 5 years younger, even 10 years younger, that can stop you and help you take a decision correctly rather than you make the mistake and you go back. Hence, always work on the 4 Ps, the purpose, the planning, the precision, and finally get in and do your surgery. The final decision is always of the patient. Keep the hubris in your head away and bend down and bow below the heart or in front of the heart of the patient. Use the URL. Unplug your head, relax your hands. Don't be in a hurry to operate them. They are all elective surgeries. And listen to the heart of the patient. The heart should rule the head and dictate the hands. Always plan with the surgeon and the patient. The patient is first and not the surgeon. Thank you very, very much for a patient hearing.